My name is David Kozlow. I'm an undergraduate in the GMU Forensic Science program, and I'm honored to introduce the following speakers. Jessie McCoy is the clinical coordinator and clinical assistant professor for the Quinnipiac University Pathologists Assistant program. She's a member of the American Society for Clinical Pathology, or ASCP, and serves on the ASCP Commission on Membership and the Workforce Steering Committee. She is also a member of the American Association of Pathologists Assistants, or AAPA, and serves as the AAPA Chief Financial Officer, as well as being a part of the Executive Committee. She serves as the AAPA Art Director and Illustration Liaison for Grossing Guidelines, and she has received many accolades that celebrate her commitment to her profession, including the 2016 ASCP 40 Under 40. Assistant Clinical Professor Lou Mendes-Kramer has served as the director of the Wayne State University Eugene Applebaum College of Pharmacy and Health Sciences Pathologists Assistants program since 2016, and as AAPA Forensic Task Force Lead since 2019. She is a practicing forensic pathologist assistant. Thank you.
Thank you. Good afternoon. I forgot that I'm definitely not under 40 anymore. But I'm happy to be here with you. I didn't include any disclosure, so my apologies for that. This is our opinion and the opinion of the AAPA, the ASCP, and I do have a special thank you to Dan. I know Dan from having worked with the ASCP on many initiatives, and so we're just really excited to be here today. So a few questions, okay, just to kind of start. Has anybody heard of a pathologist assistant? Ooh, okay. How many of you work with a pathologist assistant? Okay, a few less of us. How many of you drive a pink car? Okay, right, me neither. So what we're here today is to talk a bit about what we are as, and so up, down, I think everybody kind of has, there it is. Talk a bit about what we do. For those of you that work with PAs or no PAs, maybe give you a little bit more context, maybe some distinguishing factors between us and physician assistants, whether it be education, certification, maybe even a little bit about licensure, what we do, what we can't do, what we don't do, and then where we're looking to fill the gaps in forensics specifically. We've talked a bit about some of those workforce shortages, especially in forensics, forensic pathologists. So we are here. There are students that are interested in joining us in this field as PAs that are working in forensics. So just to give you that broad overview of what we can offer. Then we'll transition. Lou would talk a lot more about what she's doing in the field, where PAs are working, how they're working, and what they're working in. And then we hope to answer any questions. Okay? Okay. Not used to not having a clicker. So broadest sense of the picture, who are we? We're allied healthcare professionals, okay? We work in surgical pathology, which is the larger bulk of where we are, but autopsy pathology, and then now a growing subset in forensic pathology. So before we continue this, so some pathologists certainly like to make this distinction, as do we, but we can never and will never replace a pathologist, right? Much like a physician assistant or a physician associate, as they now call themselves, our role and sort of that healthcare continuum is very different, and the role we play is very different. So we always like to premise this is that is not our goal, and we never will replace a pathologist or a forensic pathologist in that setting. So as mentioned, we won't either replace them, and with that, we train under them. We are constantly, or we are working alongside, under the supervision of a forensic pathologist in the forensic setting. And so our goal is to what? Help you, them, the medical examiner, determine the cause, the manner, and the mechanism of death. And there's a lot of different ways that we do that. So just a few, brief overview. We will go into this a little bit more, but everything from photography, external examination, evisceration, dissection of the organs, selection of tissue for microscopy, finalizing that case, helping put together those slides, building some portion of the report, and really teeing it up so that the pathologist can maybe focus on different cases or other cases. Are we signing it out? Are we reading those slides? We are not. We are doing that other component to really put the pathologist in a position to be able to do better or more things. Okay. So we haven't really been around too long. You'll see that The PA profession started in the early 70s. 1969 was the first program that was created in Duke, okay, was created with the VA system. And so it was a small graduating class. So as you can appreciate, we've grown quite a bit from 1969 to now 2023, where we have about 23, this was the recent statistics, there's about 2,300 of us throughout the country that are working in all aspects of pathology, okay? And she can likely talk a bit about how many are working in forensics, but we've come a long way, okay? And there's been some really important things along that timeline that I want to focus on to kind of give you some more information about what distinguishes us from maybe an autopsy tech or a physician assistant or a physician associate, okay? So we, once we started putting students through training programs, we organized, we created the AAPA, the American Association of Pathologists Assistants. And then a few years later, in the 90s, we identified the need to standardize education, right? And so we teamed with NACLS, and let me just read it because I don't want to get it wrong, National Accrediting Agency for Clinical Lab Scientists. Those of you that work with histotechs or medical laboratory scientists, okay, that's the accrediting agency that oversees that group working with in the lab, okay? Very different than, say, a nurse or a physician associate. A few years later, we teamed up with the ASCP. Now, just to clarify, there's ASCP, the membership that provides networking, advocacy, education. That's different. There's a board of certification. That's a different entity within ASCP. And we teamed with them so that they then worked with us to develop a standardized exam certification for PAs so that we were all taking the same test and it was standardized, okay? So we now have two agencies that we're working with to standardize education and that certification process. Make sense? Okay. I need a sip of water. So the field is growing, okay? And then there started to be interest in forensics, okay? So, well, not then, but I can say that it became more robust. And it was in 2019 where Lou actually founded and established the AAPA Forensic Task Force. And so that is growing. I'll give you a snapshot of those that are a part of that, just a small snapshot, and a little bit more about where that's going. So as you can see, just a few drops in the timeline, but we've grown pretty fast, and hopefully we'll continue to grow some more. So for those of you that are wondering, okay, how many programs are there? Are there a lot of students? How do we get students in the pipeline? Or how do we get graduates coming through? Well, there's not a lot of us, okay? I think we're, 2 out of 16 programs. And so we're one of the larger programs. There's some smaller programs. But with that, you can see that's where those programs are located, okay? So with that, and this is a little bit repeat, right? So now we have standardization for both the training programs and for certification. All of the programs are master's level programs. And so what that means, at least for the majority of the programs, is there's that first year is that didactic, that theory year where we're taking courses, boots on the ground in the university setting. And then that second year, students are going out into clinical sites. They're working 100% of the time at hospitals, autopsies, medical examiners, et cetera, learning how to do those skills is what we're teaching them to do. So I brought up physician assistant, physician associate, just to kind of help distinguish. Okay, there's a huge difference, okay? Our roles are not interchangeable for 2 really important reasons. One, the agencies that accredit those programs are accredited by 2 completely different organizations. I talked about NACLS. For a physician associate, it's the ARC-PA, the Accreditation Review Commission for Physician Assistant, right? And the same thing, our certification exam is not the same. Ours is through ASCP BOC, theirs is through PNC, okay? So you can appreciate that not only is their accreditation different, but also their content, what they're learning, okay? Their theory is what? Primary care, ambulatory. Ours is not. Ours is really specific. Anatomic pathology, forensic pathology, surgical pathology, et cetera. And then that second year, those clinical rotations, ours are exclusively in pathology, forensic pathology, autopsy pathology, hospital, surgical. Theirs are not, right? Pediatrics, emergency medicine, et cetera. Completely different, okay? So just to kind of clarify that. So remember the NACLS, the accrediting agency, well, they standardize what we are supposed to be teaching in the classroom, okay? And so the expectation is that each of these programs has standards, and that standards includes autopsy technique, okay? So we're learning what toxicology is, how to obtain toxicology, and then those autopsy techniques, pediatric, adult, et cetera. Okay, so that's part of our training, okay? And I don't know if the PowerPoints are shared, but we do have links. So if you're interested in going through any of this content, you certainly can. And I'm not going to read this to you. This isn't to overwhelm you, but these are those standards that are just written out. Okay, a bit more descriptive for those of you that are interested. You know, really the whole process. Okay. In addition, you know, training, working with residents, working with fellows, management of the floor, for example, and working administratively. Okay, a lot of different responsibilities that we talk about. So once you go through a program, once you're certified, okay, then I think you talked about a coroner and how it was 16 credits every 2 years. We have 60 CME credit hours that are required every 3 years, and there's certain categories that we have to achieve those. That first category isn't related to forensics, but to cancer processing, or what we call cancer specimen examination. That's because a large bulk of the PAs that are working in hospitals and they're processing, say, a malignancy for breast carcinoma. And so there's really specific things that are needed for us to know to kind of maintain that certification. But everything else, anatomic pathology and related, that can all be forensics. And for many of those that do work in forensics, they are really specific to that. Okay. And anybody have licensure for various, is there licensure? Yeah, okay. Well, there are a few states that license PAs that required it, okay? And licensure and certification are not the same. I just like to throw that language out there. So in 2019, also on the timeline, New York State identified their desire to license PAs, just like they would license a histotechnician or technologist or a medical laboratory scientist. And so often what happens is they'll use that certification that I described as a means to validate a person's ability to be licensed. And so New York State was the first. Nevada came along, and California has licensure, but there's some stipulations. I think I wrote the details of that. But really, it's two different things. Okay, certification through examination is different than sort of whatever legal requirement or legislature that's been passed to kind of, you know, what they've done. So this is starting to transition into forensics and Lou's portion of the talk. So as I mentioned, in 2019, she identified the need to really start to bring together our PAs that were working in forensics. And so what I did is I took a snapshot of a small portion of those that are currently on the task force. I see a couple name tags represented here in terms of locations. Is anybody willing to raise their hand to say that you identify with these locations? Okay, so that maybe you're working with the PA. Do you know your PAs? Have you been able? Okay, yeah, so here we are. Okay, that's right, exactly. So, you know, and there's a lot of different models, and she'll talk a bit about those models. Some of the PAs that are on this are not only PAs, but they're also fellows. They're death investigators as well. So they serve both roles. So that's a little bit more unique, but, you know, something that's obviously very favorable. And then, of course, as somebody that works at Quinnipiac, and I train students, and we send students out to medical examiners, we can't understate how interested students are to sort of, you know, enter this when they become a PA. So many of them come to us with, you know, undergrad in forensic science or anthropology, and they don't know how to get involved. And so they find us, Pathologists Assistants, and they figure out, okay, how can I get into this? And so whether it be, you know, open houses or general information, this is how a lot of students are coming to us, trying to sort of navigate and come into this field. So we're excited to be able to facilitate that. And so I know we have been trying to grow that. And so we look forward to all of you to work with you in the future. So, and this both of us, well, so many students. So that's it. That's my sort of initial kickoff. I'm going to turn it over to Lou so she can talk a bit more about the specifics and PAs. So thank you.
Thanks everyone for having me here. I'm the one with a really long, ugly name. It's VéraLúcia, Mendes-Kramer. Lou works just fine. So I am the director of the Pathologists Assistant program at Wayne State University, and that's in Detroit, Michigan. I am the task force, the AAPA Forensic Task Force lead. I'm also a PA that is currently practicing in forensics. So I do go out to medical examiners and coroner offices across the country because I work as a locum, and I do the job that I'm going to describe in just a second. So don't be offended if that's, if that offends you, I apologize. It's not meant to, but I do want to highlight what is it that I do that I can bring to your office if there's a need. So I don't know if you're aware of this. There's kind of a shortage of board certified forensic pathologists. A little bit. The AAMC, the Association of American Medical Colleges, estimated that in general, so not for forensic pathologists specifically, there's going to be a huge shortage of primary care physicians according to specialty as well by 2033. So we already are seeing there's going to be shortages. You should be expecting that. In 2021, 46.7% of physicians in general were 55 years or older. So retirement is approaching. In pathology, the shortage is predicted to range between 17 to 42,000 physicians by 2033. This was before COVID, before we all got stressed out, before people start quitting their jobs because they were overworked. Okay, so this number came before that. So the percentage in change in the numbers of active physicians by specialty, and this is for the specialty of pathology in general, so not just for forensic pathology, has seen a decrease, a continuous decrease in their numbers. And as of right now, it's about a negative 7.7%. So in 2016, there was about active practicing pathologists, 13,000. In 2021, it decreased again, and that's 12,000 pathologists. And that's just APCP specialty in general. So the percentage of change in the numbers of first year ACGME residents and fellows between 2016 and 2021, we are seeing that when it comes to practicing, anyone that finishes the 4 years of med school, they then have to go into the specialty of pathology, 4 years of that, all right? And then 1 more year for the fellowship in forensics, right? Long road, okay. So between 2016 and 2021, again, numbers are changing, slightly increase here and there, but in general, for the past 7 years, there has been a decrease in medical students, or after they finish medical graduates, going into the specialty. So for the past 7 years, we've seen this. 2021, there were only 2,275 residents and fellows practicing. So that's not that many when you think about that number from the previous slide that indicates how, already there's a shortage. Okay. So, in 2013, Roboy and all published this predictive model of how many board certified forensic pathologists were needed to practice in the United States. 10 years ago, we were short. Okay, it said 1,100 physicians were needed for the entire country. There was the report of the NIJ to Congress in 2019 indicated it was between 400 and 500. That's a very common, approximately, there's 400 to 500 board certified forensic pathologists currently practicing in the United States. I know NAME right now is collecting data, trying to figure out exactly how many physicians there is. In 2018, there was a census that came out by the Bureau of Justice Statistics that indicated there was about 890 physicians, autopsy pathologists, the study called them, autopsy pathologists practicing. Did not differentiate between part-time, full-time, and did not differentiate if they were board certified or not. So 400, 900, we're still not meeting that 2013 report that said we needed 1,100. So let's say it's 500 that it's out there, full-time, board certified forensic pathologists. It's still not enough to fill the need that is currently affecting all of the 2,040 medical examiner and coroners in the country. And that was a census also from 2019 that came out. So if you have 2,000 MEC offices out there and we don't have enough physicians already to practice, what's going to happen? We're overburdening these people. Not just the doctors, but also the techs, also those autopsy supervisors, the coroner liaisons are going to come up after this presentation, I'm sure. But we are going to overburden these people. There has to be a resource out there for them to help them. And I would like to think that PAs as pathologist assistants are that resource. We can help you. And how can we help? It's coming up. So a little bit more information for the medical student in the crowd, right? Maybe. So there's only 166 pathology programs in the United States. And this is for this year, 2023. This year there was 613 residency or position opens that were open in pathology. And of the 613, 607 have been filled. So that's not bad. But when you look at the big picture, the match or the National Residency Matching Program had about almost 43,000 applicants for all of the 50 specialties. The highest number of specialty that received or that has open positions is internal medicine. You want to guess how many? Almost 7,000 open positions. I mean, when you think about pathology having this and then internal medicine having, 6,900 something, it's a big discrepancy there. Okay. 69 forensic fellowships are now offered. It's first time ever. It's not offered through the match. And 73 fellowships were available for 2024. I'm going to be honest, I tried to get the data of how many for 2023 fellowships in forensic were filled. I don't know if you know fellows that were accepted fellowship in forensics, but I asked, there's a bit conflicting numbers because the match and not all positions are in the match, but maybe 40.
Right. Well, what I heard one student that I was aware of attempted to match, but didn't, and so all the programs had been built.
So maybe we have 73.
Maybe.
Let's hope so, because NAME is really doing a great job trying to recruit medical students and trying to put the word out there that there's a great profession, and it is a great profession, and they're doing a great job. But there's a few years until that comes to fruition, and in that time frame, you need to, as offices, medical examiner and coroner offices and practitioners, to consider another option until the med students can, those of you that are going to go into the profession actually get there and really make a difference, because you can. So that's us, I think. But I'm, maybe I'm not the person to say that it's us, but I think we are. I think we can help as PAs. And I wanted to show you a short map here. We're not everywhere. All right, surprise. We are not a dime a dozen. Nobody laughs at that because we weren't at NAME last time to hear about the comment of the dime a dozen. We are not a dime a dozen. There's not that many of us. And and as Jesse said, a lot of PAs that graduate, they, with a PA degree, they practice as search paths. They don't practice in forensics. A lot of it because there's not that many offices that know about us. And a lot of people think we're very expensive. But there's also this concern about having PAs. I'll talk about the concern in a minute and why should you be or should you perhaps not be concerned. But these are the states where you are going to find PAs currently working. 2 states have the highest number of PAs in currently practicing forensics. That's Minnesota and Michigan. Minnesota has a very interesting, Mayo Clinic in particular, has a very interesting system. This is something for you to consider. Having a PA can actually help you in 2 different realms. It can help you in the autopsy suite, and it can help you in the medical investigator setting. When I graduated from my PA school program, I worked in Michigan, and I worked as a medical examiner investigator / that was my position / forensic PA. And I would go to the death scenes, the crime scenes, and I would do the investigation. And then the next day, I would assist my attending with the autopsy. So it was like a full circle. And there's to my knowledge, there's 2 offices that are currently doing that model. And that was the one in Michigan where I was at, and the one in Minnesota where they were using the PAs for that particular purpose. And the reason for that is that we have that medical background. We have that pathology knowledge, that disease process understanding, that we can go to the death scene and talk to the family of the decedent and get that information. Oh yeah, they were complaining about sudden back pain, but they were fine, but then a day later they died. And to most people that don't have a medical knowledge, that's like, oh, poor guy, maybe shoveling and hurt his back. Well, maybe they did, but maybe they have, an interest to play. I mean, who knows? But I know to bring that in. I know to question that, and that would make me puzzle. So I would bring that decedent in versus releasing it to the funeral home. So that is a system that is currently very successful, in particular in Minnesota, because they have very high number of PAs currently practicing there through the Mayo Clinic, and they're all certified. I always say the acronym wrong, so forgive me if I do it. ABNDI, certified. So there is a different system out there. Other counties, and forgive, I know the DeKalb County is here, and I'm sure they can talk to you a little bit about it, but I know the PAs that work there are involved in other programs within that particular county. And whether that is in suite investigations, whether that is in public health programs that you are offering within your county, PAs can be a resource for you. Wayne County Wayne County PAs are, not currently doing the medical investigator portion of it, but they are in the process of considering and instituting that. They are a county that has been for many years now accepting rotating PA students to train, to then allow them to, do all of the autopsy and everything that they need to. So they're trained there, and as they're trained in DeKalb County, they're trained in Mayo and other places, but they are trained in specific forensic techniques that are, part of that system that can be translated to other systems across the country. So how can we help? I keep saying we can help, but how can we help? So if your office is currently struggling to keep up with not only just the number of the autopsies you guys have on a daily basis, but all of the other stuff that comes with it, this is where PAs can be of assistance. We can come in and take over some of duties that will release your time for perhaps manage more courtroom responsibilities, complete those reports that are pending, maybe hopefully for just last week, right? Ensure that there's protocols in place for safety for all of the staff. Ensure that you are abiding by accreditation standards. Do you have what it's needed to maintain your certification? Maintain or attain that quality improvement and quality assurance. All of the logistics, administrative, requesting medical records, all that, PAs can do that for you. They can do those medical record reviews. If your office also takes in residents, teaching responsibilities, a lot of what Wayne County does with their PAs is the residents that come in, they go straight to the PA to be taught. I don't know, how many of you are pathologists in here? How many of you were trained by PAs on the grossing skills? Texas? Okay. All right. Nothing makes sense. But that we can train you. If we can train you in search path, we can train you in forensics. I promise you, we can. So here are the various responsibilities of a PA that is currently working in forensics. This is what I do when I go and I do a locum in any of the offices that needs me. I can start by doing a medical review of the cases that I'm assigned to, or in cases that, if I have an extra time in a few hours on a slow day, they might assign me additional cases for the medical records review. I start by doing external exams. I collect trace evidence. I eviscerate. I do a block of organ dissection, whatever the office prefers. Latoul, Gu, Kotansky, Virchow. I'm trained in all of them. I can do it all. Brain evisceration, brain dissection. I collect toxicology. I cut my tissue for histology. I can also take pictures. I also do the preliminary autopsy report. No guns out there. Okay. I do that for my attending to sign. Okay. My attending signs. I can also assist with collecting research data if necessary. I'll tell you, in every place that I've been, I've worked with fantastic techs that half of these things I don't need to do because I have phenomenal people working with me. So I usually, when I go and do a locum, I don't do the evisceration, I don't do the pictures, I don't do the toxicology, I don't do the collection of trace evidence if necessary. I don't eviscerate the brain. I'm given I do the external exam, I do the block dissection or the organ dissection, I do the brain dissection, I do collect toxicology, and I do the preliminary autopsy report. When I go into a medical examiner's office, my workload in a day, depending on the case, is about 4 cases. Now, depending on the case, I could be doing all 4 naturals or all 4 ODs, depends on the case. And what type of cases do I do is coming up. This is the point of contention that I mentioned earlier. Am I just thrown in there and stolu into the cases? No, all right, I'm not. Because as Jesse said, we work under direct supervision of an attending physician. What is direct supervision is subjective to that attending. This is a statement that is currently being proposed to the new name standards of what is direct supervision. So direct supervision is done in person, where the forensic pathologist is readily available, physically present throughout the autopsy to give both supervision and guidance to the pathologist assistant. If you need me tomorrow to go into your office and you've never worked with me, I would expect for the pathologist to be in the office with me on the floor, making sure that I know what I'm doing until you're comfortable with that I know my stuff, so that you feel confident that perhaps you can work in your office, which is in the same building, where I can call you and say, hey, can you come down for a second and take a look at this? Because I don't know what this is. I want you to confirm it, or would you like to take a look at the organs? It varies so much per office, per attending, what direct supervision, what they feel comfortable with. I work with whatever feels comfortable to any of my attendings. If they want to be standing next to me, over me, by all means. I love talking as I'm doing the autopsy, so not, nothing can shut me up, so I am good. But it really is up to the attending. If you don't feel comfortable having, being in your office locked, not seeing or not being present on the just in case, I understand that. We all understand that, but it really is up to the attending physician. So what kind of cases can I do or have been involved with? So whenever there is a PA going into work in forensics, this traditionally are the type of cases that they are doing. Natural deaths, ODs, MVCs, suicides, drownings. Traditionally, those are the types of cases that I do, but I have assisted my attendings with all sorts of other cases, more complex cases. Some attendings, some pathologists, I should say, have a problem with PAs doing these cases. Others are comfortable and confident in our knowledge base and our understanding of pathology, that they're okay with us doing these cases. Again, it's going to be subjective to the attending physician and to that office. One thing to consider is, as much as you might want us to be working in your office, legislation in your state might not permit that. So legislation is something to consider as well, because who opens the body and who can perform the autopsy is specific to that state.
So the natural deaths, ODs, and suicide aside, for motor vehicle accidents or drownings, if there's potential for civil or criminal or litigation, is that where someone with a pathologist would maybe want to be there?
Yes,
but if
correct.
it's something that was like, not in the shoot, that it's usually okay.
Yeah, that's exactly it.
Because I would imagine the possibility of having to be in court around any case is what's going to bring you.
And that's always the concern. I mean, but if you think about it, any of these cases, you selected just those two because that could be a legal implication. But I mean, honestly, what comes through as a natural death case could just as easily in the middle of an autopsy become all of a sudden a homicide. Well, now what? I just did the whole thing and there's that uh-oh moment. What does that make a difference? Does that change anything? I just did it.
And I would say that those same pathologists, if they're working in a program where they are training forensic pathologists or residents, oftentimes those residents or pathologists will do not only those cases, but homicides as well. And those pathologists have to sign off on that, so they take responsibility. So if you're the forensic pathologist who's responsible for the case, I mean, ultimately you've got to take responsibility for the whole thing.
Yeah, I mean, it's just like in surgical pathology. We work under the pathologist's license. So who's going to be called? It's always, so you're going to go to court and you're going to, present about that? No, because I'm working under your license. So just like I wouldn't in a surge path case, if I have a breast and I'm grossing that breast for breast cancer and something wrong happens or I did something, God forbid, it's still going to be you who's going to go to court. So it's just, again, I'll go back to comfort level. Are there good PAs out there? Sure. I hope those of you that work with me, I hope I'm a good PA out there. But there's also not so great PAs. But I'm sorry, doctors, are there good doctors out there? Are there bad doctors out there?
Absolutely.
Okay, thank you. Thank you.
I think another contrast that probably most everybody in the room knows, but I just want to state it just so it's clear, is that when I was a resident doing autopsy, I would be in the autopsy suite with a tech, not with a PA, just with a tech, and I was doing the autopsy, and the pathologist was not there. They would come at the end of the day to look at the organs. And it was my responsibility to say, when I was in the middle of it, to say, wait a minute, I think we need to call the medical examiner. And I would call my attending and say, hey, can you come down? I think we call the medical examiner. And they say, yeah, you can call the medical examiner. But you're still under their license, so many different responsibilities. And my level of training at that point was exactly the same level of training as a PA, right? You've had 2 years of training grossing. I had a year or two of grossing. So the scope of practice challenge that I think that name throws out there is that's a defense, that's a problem for that, because we have residents that do it that way, and it's the same level of responsibility. So I think it's kind of a double standard.
And just to add to your comment, I know some forensic pathologists who will have a on-the-job trained pathology assistant with no formal training whatsoever, do cases in evisceration. And then, you know, they'll come in and they'll take care of the rest. But in terms of how much hands-on and direct supervision forensic pathologists have varies considerably. I don't know, you're a forensic pathologist? And who else is a forensic pathologist? Okay, I just was doing, are you familiar with what I'm commenting about?
Yes, I am. That's not my style.
Yeah, not my style either. It's like, if I'm responsible for a case, I need to see it.
Right, Yeah.
My eyes are on it, my hands are on it, and
Right.
I'm there.
and I'm one of those, I mean, if I'm training a resident or a fellow and I'm giving them a case to cut, it'd be on a day that I'm in the morgue. And so I may be doing a case where I'm right next to them and I can still walk over and look and talk to them about it, and I'm still readily available and I'm in the morgue. But
So in that same sense, would you have a PA working, doing exactly the same thing as your,
yeah, I mean, I
Fellow.
would definitely be comfortable being right there and knocking out the case list. You know, together, we're in the same morgue, it definitely fits, you know, the direct supervision, and it's easier, I mean, and you have each other to go back and forth and, hey, what do you think about this? What do you think about that?
Not just the way, Patrick, from the gas. On a routine basis, and those who've got officers know how busy we are. On average, we do have 2 women in the lab at a time. So you got two cases, which is a, not just one, you have 2 homicides doing simultaneously. The doctors are focused on the prosecutable cases. Of course, you still got natural cases, you still got ODs, have other cases that need to be addressed. They have been a jewel for us in that they're in the lab. You have 2 doctors there that, and I've seen this myself while downstairs doing my routine walking and looking at that. They'll go, hang on a second, the doctor come over, they'll consult, they'll review that case, and if there's a need that need to step back, the doctor is in control. That happens. That happens. So the system works, and again, it's on the level of comfortability with that ME, whether it be associate or the chief. The chief, I've seen him downstairs with 2 PAs, and he was the only doctor in the house. And of course, he handled each one, he oversaw all cases, but he was comfortable with the PAs working those cases that he assigned to them in the lab.
You establish a collaborative working.
Correct.
You're basically the team. You work together to accomplish the goals. So you're right.
And on the other side of that, you know, we also get a DC review that pounders to know in. The PAs, you know, the investigators are investigatively trained. So mine and my office are closer by the law enforcement training. They're great at going out in the field. They're great at interviewing in the field. Medical record requests can be depending on their experience level working in the office. The PAs represent that because they know exactly what the doctor is based on their work for that case. So you're not getting the local grade result, sending 2 boxes of medical records to review. Yeah, that's what looks like face. They're focusing on that specific case, and those records are being brought in that are needed. So they can review ahead of time and consider that consultant.
You do cremation reviews? Yeah.
We do not, yeah. Let's see, legislation about that.
Yeah.
So you kind of.
so, the feedback that I received as a director, as a PA program director from offices that have hired, my students is that, having hired the PAs, they feel that there has been an improvement on turnaround times. That it has allowed them to prioritize those cases, those, as I was saying, those homicides that they are being assigned at the PA, they're just focusing on that case versus not having to worry about, the 3 other or 4 other cases that they have, or 10 other cases that they have come in that day. It has allowed them to provide a more thorough education to residents that come and rotate in their offices, and also allowed for a more organized distribution of the resources of the office, whatever those resources may be.
So, this is a quote from Dr. Webb, who presented a couple of years ago, at the NAME conference about PAs. And, you know, he was at Wayne County at the time and having PAs in his office. He felt that there was, it had not jeopardized the quality or the integrity of their service, but rather it had allowed us to address other vital needs, many needs in a medical examiner's office. You know, these are our references, and I'm happy to answer any questions.
I have a question. Well, it's like a two-part question. In Minnesota, do PAs require licensure?
No, so there is no licensure. So there's licensure requirements in just a few states. But in terms of a PA, for a PA to practice in the majority of states, certification is sufficient.
Okay.
So New York requires licensure. The Commonwealth of Virginia, if I'm not mistaken, I think there's only 3 states that requires licensure. Texas is not one of them.
But since 2009, in order to be certified PA, you have to have gone through a program.
Yes.
So there's no more OJT.
Well, the main reason I was asking that is because since COVID, physicians assistants or all mid-levels in Minnesota are now able to have their own practices and don't have to be supervised by a physician. They just have to have a contract with them, because I have a Minnesota license and I have a PA that I work with there. So I'm just wondering, as far as licensure, if you guys would end up having the same autonomy as the other mid-levels that are in the state.
So we have autonomy in the sense that if you wanted me to go practice in Louisiana tomorrow, you wouldn't have to request, there wouldn't have to be a license being requested for me to work there, because my certification is sufficient to allow me to work as a PA in forensics there.
But she would only be working under a pathologist.
Yes.
Right. So nurse practitioners in California are the same as PAs in Minnesota. After COVID, they could basically have their own practices, and it's a big point of contingency. But their training is totally, as Jesse was saying, their training is totally different. It's clinical, and their filling primary care roles and triaging people into higher levels of care. For PAs, the unsupervised things that they can do are things that you wouldn't do anyway. Like putting on biopsies, like you wouldn't do that anyway. You can get high school students to put biopsies, unfortunately, right? And most people do. But for Lou to go in, like gross in breast, someone has to look at it, right? And whether or not, this is a great question, actually, whether or not you could go to a substation, for lack of a phrase, and gross in everything, and it goes to a central lab. I think you can do that,
Yes.
as long as ultimately a pathologist is looking at it. But there still has to be a pathologist that's responsible for that.
So we don't do the histology, the diagnosis part.
Right.
We do not diagnose, just like I don't determine manner of death, but the information I collected at an autopsy can lead to the cause of death, right? But I'm not going to say, this was a homicide. No, that's why you went to medical school and got all those years of training. Just like, for the histology, can I look at a slide and say what it is? Sure. Am I going to know? Because that's diagnostic. Do I know PAs that do it? Absolutely. But that again, comfort level of the PA, of the attending about the PA.
So in the states that require licensure, those few that you mentioned, because they're not working under a physician's licensure, are their employers, the people who employ the PAs, now responsible for paying malpractice on them?
So they still have to work under a pathologist, even in the licensure state.
Okay.
It's just, it's kind of I don't know, licensure is a weird thing.
It is, because even though we are not licensed, we can't obtain the license at that state. Like I have graduates of mine that are working in New York. And it would require license. You just have to apply for that license. You just pay more, go through more paperwork. It's what it is. It doesn't change anything. We will still work under the direct supervision of physician.
A good example, I think it's New York. In New York, the office that handles licensure for laboratory professionals is the same office that handles it for barbers and hairstylists. Like it's a money thing. It's not and so for example, in California though, which is a good example, the licensure is ass, because you have to be certified by somebody, or you have to have a year of working in the state. How do you work in the state if you're not licensed? It's a ridiculous way to just, to create barriers for that. So that's why it's only 3 states.
Yeah, there's Go ahead.
And just to add to that, so think about when I was using the example of a histotechnologist or a medical laboratory scientist that might be working in the lab, they're also those same individuals that are licensed, say, through New York. So it's not licensed in the sense of like a board certified licensed pathologist. It's just this layer of legislation that's gone through. And some use it as a means to protect the patients, right, from having someone that's not a certified PA or not a certified technologist, et cetera, from bursting a breast, performing an autopsy, et cetera. That's what they say, but.
You know, it is a consideration for a lot of offices that are struggling with finding physicians or keeping their physicians because it does help that workload. We are not replacing the doctor. We're not taking away doctor jobs. We just want to ease your load. That's all. And, you know, for the offices, keep the doctors. We want you to keep the doctors. Having a PA is what it's going to do. Help the doctor's workload and decrease the shortage in your office. They're not going to go away because you don't have the resources that a PA can bring, a PA being the resource, into the office. So,
Another financial thing is, let's say you don't have a forensic pathologist in your office at the moment and you really need one, or you have two positions open. I live in Riverside County. That was the case for several, it still is actually. They can't hire a PA because they still have to have a pathologist. But once they have a pathologist, they can take the salary for that other pathologist and hire two PAs, and now they can actually do their work, right? So I think that the cost effectiveness is not really half, but cost effectiveness of having a PA, especially a locums one, can really help that one person get their work done.
What is the salary range for your PAs that are leaving your program?
so it depends, really, it depends on the state. In Michigan, it's about 80 to 85. But I know of states that are paying about 120, 140 to the PA. So if you are thinking about how much your office has that budget line for that attending physician, for that board certified position that it's been open for a couple of years because you haven't been able to fill it because there's not enough doctors going out there. And then when they look at the numbers of autopsies you're doing and they're like, you want me to do what? You're out of your mind. No way. Thank you. I'm going to go to the other place. This is where you're going to be able to justify, hey, I can hire two PAs for that one doctor and help the entire office in multiple areas, not just my the doctor that's already there, but help the office in multiple areas.
And just for reference, so if you Google or look on the internet or whatever, it will tell you that the average salary for a practicing forensic pathologist is $110,000 a year, which is, that's just a number. And the average practicing for a regular pathologist, a non-forensic pathologist, is like $240,000 a year. Those numbers are garbage. If you actually look at the positions that are open for forensic pathologists, the average salary is $240,000 a year because they can't hire people that salaries are going up. And for practicing pathologists, open positions, it's closer to $300,000 or $400,000. So that data is not helping us recruit people. So we really have to look at the open position data and really promote that to say, look, these positions are actually paying really well. The other thing is that almost all of the open positions that I've looked at, there are 39 or 40 that you can find that are almost always available. Almost every single one of them has some kind of loan repayment program. So that pathologist can get paid. So it's not a financial problem. There's aren't enough people going into forensic pathology, and we have so much desire from PAs. It's just the right opportunities. We just have to convince them.
Just piggybacking on that, environment means a lot. When you come into an office and you're showing the doctors, and doctors are trying to get the case back, they're trying their best. And then you a new fellow coming in, whoever you come in, you see the stress level in the environment. That compounds on, do I really want to continue to do this? Or do I want to walk into an environment with case so heavy? With, I always speak to us, when you got that additional resource in the office, is helping you learn in that environment along with the technician. That promotes it because they not only do that as a practical night in the office, we allow them to outreach, step outside the office. This is where you can learn, this is where you can grow, and then step out into the profession to do what we do here. So for us, we know there's a shortage. My staff heard me say it the last 10 years, we got a building. We gotta build doctors. Because there are not enough of them out there. They're helping us build doctors, period. There's no other easy way to do it. Because there's a shortage, we've got to start building positions to do what we do, because as the guys with a lot more experience, they're starting to step away from the profession. We've got to have somebody to help fill that gap. And they're helping us fill that gap from a practical standpoint and help with the regular. And they're not replacing our doctors. They are not.
I can actually, speak to that. I'm a resident at the University of Toledo. Our rotations are at the Lucas County Coroner's office. And in the past 2 years, I believe they've implemented, pathology assistants. I know Ally, I saw her name up there, and I have to say, ever since they joined, our Lucas County Coroner's office, it has freed up so much time and availability for our learning, which, I mean, it's amazing. Not only from the PAs, but also from the attendings, and the environment has shifted so much, because before as a resident, you don't want to feel like you're, like delaying stuff or like being in the way. So when things are finally starting moving along, when we're going through our case list, it actually was a very nice feeling, to feel like you're part of a group where everybody's relaxed, being able to get through cases. And I recently applied to the forensic fellowship. I was part of the match. The numbers, I mean, I thought the activity was a lot higher, but they actually sent out a breakdown of the applicants. And I was surprised to learn that there was only 47 applicants for the match this year. I believe, so 20 programs were able to fill, 21 unfilled, meaning they had maybe one of their 2 positions, and a total of 13 had 0 fellows.
So out of those 46, how many of the doctors in all of these 2,000 counties, if they have a position, are going to retire, about to retire, or they're burned out, that they're like packing their bags this moment, and they're like, sayonara, I'm not saying, because I'm overworked. 46 is not gonna cut it.
Right.
And then of those 46, then how many will complete the program?
Right. There's that.
That's worth certification.
That's that.
How many will stay within practice?
But for the medical students here, it's a great profession. You guys, the residents, you should go, you should keep going, because it's a fantastic position.
Hey, you haven't talked to them yet.
You don't want to have it because there's there's PAs and they're gonna help you. Yes, ma'am. Yeah, there's a question back there.
Oh, yeah. So it sounds as though it like, from the operational side, it's really helpful to have, the pathologist assistants. Do you know if there's been any, it looks like a proposed change, if I'm hitting like a wall where I can't read that document online.
Oh, sorry.
Do you know what name has done as far as adjusting the caseload to keep accreditation, like at all?
That's exactly what I was thinking.
If an applicant, let's say, really overworked and they need to lower the number of autopsies, is that going to count?
So right now, last year, for the first time, Maine proposed several changes to their standards, several of which included PAs being involved. So right now, as it stands, the standards do not acknowledge PAs as mid-level providers as they do for physician's assistants. So they put this at the same level as an autopsy technician. That's a problem, because then when you get budget-wise, it's a problem, because then you don't have a budget to pay a PA at the level that they need to be paid. That means nobody's gonna take that job. So that's a problem. But where does this stand now? It was proposed last year, it was voted, a majority voted against changing the standards. I don't know if you were at the meeting last year, those of you that were, I think you were at the meeting last year. There was a lot of communication
about a lot of expressed feelings as to why PAs shouldn't be involved, and should not be part of the standards. Some of those comments were valid, some not so much. I think a lot of it stems from lack of understanding of what PAs can bring to the table. Do I think it's going to change? I do. I don't think it's going to change this year. My personal opinion. Hopefully it will.
Yeah.
I don't know.
Well.
The dots in the place.
And then on volume, you know, if you look at the Canadian system versus the US system, Canadian system, they're all about how much work I get done per hour. And they spend a lot of time saying, this is how long it takes me to gross the breast, this is how long it takes me to do the histology, this is how long it takes me to do an autopsy, because they have to argue to the government, you need to hire more people because I've got my maximum. That's very similar to what forensic pathologists do. It's not what people do in surgical pathology. They want to do as many cases as possible because they get paid for every case. But in forensic pathology, it's the opposite, right? It's very stressful. So I've talked to multiple forensic pathologists about, you know, how can we recalculate or look at your workload to determine what the right number is, and they won't even budge on it. It's 250, it's 250, it's 250. It doesn't matter who you ask, old, young, new, but no, it's 250, it's 250. They don't want to discuss it at all. They're just going to keep it at 250. I don't know why, it's fine. But if they were to actually re-look at it in a different way, you know, you might say that if you're doing, well, you're only doing full autopsies, then the virtually closer to 200 or 175. If you're doing partials, it's closer to 300. Like, oh, it doesn't matter. On average, it's 250. So they're just not willing to budge on that number.
Well, I apologize, I'm a lawyer, but. Sorry. When you say a partial autopsy, you mean only a partial autopsy is being done on that deceased?
Yeah, so maybe it was just the head that needed to be
I'm
open.
only been part of it and have to doing.
Right.
No.
The procedure, the procedure.
Examine it. Just examine it, yes.
Yeah.
So that has its benefit, it frees up some time, but you leave a lot on, I mean, they're going to destroy the body after. But you can't overlap plans, so that's thing. So for forensics especially, forensics is the original overused profession. You can't overlap. Somebody's destroyed. So take samples, take histology, have keeping jars. My office has jars and jars of people. I know New York office has warehouse somewhere in Brooklyn just for this from. And I think every big office is gonna have the same thing. In here, I just moved all my stuff off the offsite, the bigger storage facility. But when an officer like that, you don't know what somebody's gonna ask you. You don't know. Because of the case, a lot of offices, a lot of examiners have to just do partial. Just prove my point. Die from the throat, die from heart attack, and move on. It's
And that's
not
the
good.
process.
It's not good medicine, but.
We normally don't do partial. If it appears natural, we won't do a partial, but we will do a partial if it's a homicide and it's obviously the shot in the head. There is no need to, do everything. That's basically what our partials are, really directly related to what we know it is. There is no need to, I mean, if it's a shot in the body, that's it's a headshot. I mean, that's how we do our partials. We don't do partials.
Yeah, that, all of that really varies per office.
Yeah.
I mean, I've been in offices where, you know, a GSW to the head, a suicide GSW to the head with a letter that's been, you know, authenticated by the family, with a gun still at home. I mean, there's enough proof that it's been a suicide, GSW suicide. They still want a full autopsy. Other offices wouldn't even consider doing an autopsy. Other offices will want to just do the head, just to collect the bullet if there's still bullet fragments in there. So it really varies so much according to the attending physician, the office, the state, the county, the state, and so on. Back to your initial question of the numbers, will name change those? I think it will only change those numbers if once they're able to really incorporate PAs into their standards. IECME is an organization that was also
changing their standards, they reached out to the AAPA task force and requested a potential statement of how things would look. We collected information from all the members of how many cases we do, how, what can be done in a medical examiner's office for a PA in terms of caseload, and what type of cases, and how could that translate into the number of autopsies an attending could claim. But again, PAs are not in the standards, so that kind of goes.
But that's a big gray area anyway, because, I mean, so the accreditation standards for the lab to be accredited, name says they want you to be under 250 per doctor, per full-time doctor in the office. You take the whole number that they have and you divide it by the number of doctors and you hope it's that. But say like residents or fellows, because they have to be signed out by the attending physician, that number still falls into the number of full-time physicians. It's not divided again, like, oh, we had a fellow that was taking this. And so then it would be the same type thing, I think, like, how do you delineate, like, oh, well, a physician still had to sign off on all of these, but PAs were doing the majority of the autopsy. So then it makes it really hard to decide, like, autopsy standards, what's too much and what's.
And that's just for there's 90 offices in the United States which are accredited by name. And so the vast majority are not. And there's no restriction or limitation on what they do. You'll have some pathologists that are doing 3, 4, 5, even 600 or more cases per year. And it may be, by default because they're the only one that's available. But then there are those pathologists that are using that. They're using it as a cash cow. Because the salaries are not really there necessarily in all jurisdictions. And if they can do more and more autopsies, then it improves their level of which is helpful.
And I've heard from a chief medical examiner from an office that told me, we are so overworked in here that I don't care about losing my name accreditation if that means I'm going to have PAs coming in to help me. I don't care about that because I need to think about my people's quality, my people's quality of life.
And the accreditation is fairly optional. There's no mandate that you have to have any accreditation.
So in my jurisdiction, they actually just asked the legislature is not working as pathologists, and they're not having a person that passing on something that happened. So I'm not sure if anything else.
Where are you from?
Maryland.
Helping us move the needle, so to speak, is this is starting to impact human services as well, which means it also impacts families who have to wait to handle their financial responsibility. Ultimately, that's our job, is helping those families resolve their issues. And the longer it takes, unless your needs, that has an impact. And there's a large number of those folks. So understanding that, there's human service industry now, so it's starting to be impacted by that, progression gap. And it's starting to walk but you're not aware limits people. Yeah. Your number
No, it's been in place for many years. I don't know if Dr. remembers what the 200, the number of 250 has been in place for years.
in me. It's the same as the one.
Well, if you think about 20 years ago, let's say 30 years ago, let's say it was instituted 30 years ago, the number of physicians 30 years ago was much higher. So it made sense to, 250 will never get there because there's enough doctors. No, there's not enough doctors, and the 250s are becoming like
Exactly.
550 is only a phase 1 deficiency. You can get up to 325 per doctor before you would lose accreditation.
So between 250 and 325 is a phase one of this.
Yeah.
Okay, okay.
I know you all want to